Hello and welcome everyone. This is Caleb from the National Rural Health Resource Center and the task team. Today is, I think it's Monday, September 10th, and this is our September Virtual Knowledge Group call, and we have it on the 10th as opposed to the 3rd due to the holiday that was last week. So thank you for joining us, those of you who are able to join us live, and those of you who are not, happy recording listening. Today we have John Gale from the Flex Monitoring team, as well as Scott Daniels and Jill Bullock from the Hawaii State Office, as well as the Arizona State Office of Rural Health, to talk about PIMS, the Performance Improvement Measurement System. A couple weeks ago, Sarah Young from the Federal Office of Rural Health Policy had a webinar talking about PIMS and how to submit your data, log into EHB, discussing some of the background and reasons for PIMS and how to submit your data. This webinar today, as with most virtual knowledge group calls, is much less formal. We don't have any presentations created. We're really here to talk about and to chat about PIMS and the reporting processes, data collection methods that different Flex programs use and utilize. So if you are participating or listening to the webinar and have questions and would like to participate, *2 will unmute your line. And please interrupt anyone, including myself or any of our presenters, to talk about and chat. Any questions you might have, please utilize the chat feature. But we like to keep the virtual knowledge group webinars pretty informal and discussion-based. So if you have any questions or we're not covering something that you would like to make sure we do, please interject and let me know. Some of the upcoming events and news that we have: the National Rural Health Association's Rural Health Clinic and Critical Access Hospital Conference will be held the end of the month, September 25th through the 28th in Kansas City. The NOSOR, National Organization for State Offices of Rural Health, annual meeting will be in Cheyenne the 16th through the 19th, or maybe it's the 17th through the 19th, in Cheyenne in October. We have the Flex Workshop here in Duluth the week of the 22nd. Registration for that is all full, so if you or someone in your office is interested in participating, please reach out to Shannon Greeley and we will get you on the list for the April Flex Workshop. If you have any new staff or staff who have left your Flex program, please reach out to Shannon Greeley at the task at ruralcenter.org to make sure we are aware of that, those changes, and we can make sure people are on lists. Anything else that I'm forgetting, Shannon? Again, this is Caleb from the Task Center at the National Rural Health Resource Center. John, are you on and unmuted? I asked John to participate in the webinar today so we could talk a little bit about the methods and ways that Flex programs could utilize their PIMS data that they're reporting to help inform some of the activities and programs and services that they provide to their different critical access hospitals.
I am on, Caleb, and so whenever you want me to begin.
Howdy, yeah, thanks for joining us, and yeah, I'll let you take it away. And again, if anyone has any questions for John, please utilize the chat feature to the left there, or *2 will unmute your line. And as just a matter of formality, we like to kind of get a baseline understanding of where everyone's knowledge and understanding on PIMS or whatever topic it is that we're talking about today. So yeah, John, please take it away.
Sure. So I'm going to talk to you a little bit differently about something a little different than completing the PIMS, but to talk to you about how we're envisioning the use of PIMS for the Flex monitoring team, and to provide some thoughts about how you might be able to use it for your own work. As most of you probably know, the federal office is very interested in trying to document the impact of the Flex program. I don't know that there's much doubt in anyone's minds that the Flex program is important. It's helpful to hospitals, and the states are doing good work, but we really need to be able to document that. What we know and what we can prove are often two different things. And so we're working a lot with PIMS, and we've provided feedback to Sarah Young and others in the office on PIMS, and have worked with Caleb and others at Task as well to look at and provide feedback. But what we're doing this year, and I thought I'd tell you a little bit about it to give you a sense of what we're thinking, is to begin to move the PIMS data into our evaluation framework more heavily. And the reason for that is obviously it's a one data set that we have, if filled out correctly, tells us what hospitals are engaged and whether or not they're improving. And so while that sounds fairly easy to do, there are some challenges. So the project that we're doing this year is we're working with the University of North Carolina, the folks at Chapel Hill, to evaluate participation in either financial and operational performance improvement activities and the impact of hospitals. So some of you may remember back in 2014-15, if my memory serves correctly, they produced a policy brief that tried to measure whether or not a CAH, it was a hospital level analysis, and whether or not a CAH participated in one or more activities, and if they did, what was the impact on quality. And we found, and they found, and the folks at North Carolina found, there were some challenges to that. While PIMS will tell us what hospitals are participating by category, so for example, in financial and operational performance, you have the initial 201 activity, which is required if you're going to do work in this area, and whether or not are you doing some sort of an assessment to determine what the needs are. The second is performance, financial improvement. 203 is revenue cycle management, and 204 is operational performance. So within each of those categories, we will have data that tells us under 202, for example, how many hospitals were participating in financial performance improvement activities. And while that's good, it doesn't tell us much about the content and the intensity of the activity. And why that's important, I think, is that there are multiple ways that state flex programs work with their hospitals. In some cases, it's around education. And some states will do a benchmarking report. Michigan, for one, they have a consultant that tallies the basic operational measures they're interested in. I believe Bailey does an analysis and a benchmarking report categorizing the hospitals by high intensity, low intensity, and high performing, medium performing, and low performing is the better way of saying that, sorry. And then working with the low performing hospitals to take on specific initiatives. So there's both the education piece where they put together the benchmarking report and they share that with their hospitals. And that's important, but if a hospital doesn't take on, so that's educational, it's useful, but the real intensity is whether or not they're taking on a performance project related to some level of financial management, be it, say, a a charge master analysis, a review of how well they're performing for a particular activity, or their cost high or low, those sort of things. So what we're trying to do is we don't get that intensity from and we don't get that from PIMS. So what we're doing this year is modifying it. So we're working with UNC, and we'll be creating variables for each of the state activities to measure whether it's educational, and it's really, for lack of a better way, and certainly it's not intended to be critical, but an active versus passive activity. Is it a meeting once a year or twice a year or more with the CFOs where they get certain data and they talk about strategies, or do they take on specific activities? Are they involved in performance improvement networks? And so I think for us is we really have to get to that level. And then as we look across the 4 areas of activity, one of the things that we're struggling with is whether or not participation, whether the assessment activity is actually an active activity for the CAHs. So if the state office is developing a report and distributing that, how do we capture that as part of the engagement process? So there's a lot to do with that, and we're going to be working through some of those details and methodology, and we'll certainly reach out to some of you and to the federal office and to folks at task. But one of the things that I think we want to think about and really is try to capture what that means. And then as we look across all 4 areas of activity, the assessment, financial improvement, revenue cycle management, and operational performance, is the hospital participating in, is a measure of intensity, are they participating in 1, 2, 3, or 4 activities? And so all of this is going to be done over the next 6 months to 8 months. We're creating a data set, and we're really trying to get to the point where we can understand using PIMS and then trying to add in some variables that let us capture the intensity and level of participation is a way of really trying to document what's going on. Not an easy task, but one I think is if we're successful, will be very important for all of you and for the federal office. So that's a long-winded way of saying. Oh, go ahead. I'm sorry.
No worries. So can you talk a little bit about, are you going to be, or Flex Monitoring Team going to be kind of stratifying those types of, in quotes, interventions, and identifying like an idea of an expected outcome between an on-site financial and operational assessment where we talk about charge master review and billing and coding practices? That's a very different intervention than sending an email out about the delta of your days cash on hand over the last 3 years.
Yes, we're going to work towards that goal of stratifying the activities and capturing levels of intensity across the programs. Okay. And I think the reason for it is that it's hard to know. I mean, looking at whether a hospital is participating in 1 or more activities under program area 2 is important, but it doesn't tell us what's successful. Now, we may have to move to this carefully, and we may have to do this incrementally as we move along, but I just wanted to share with you the sense of the challenge. But that is one of the goals, is can we determine and provide evidence to the office not only whether or not the Flex program is making a difference in improving financial performance and operational performance, and if we can get to that stage, that's the first goal, and that will be very helpful with Congress and with other policymakers in terms of supporting the Flex program. The next level is, can we figure out what's causing the improvement, what is the most effective way to drive performance improvement, and what's successful and what isn't. So Catherine has asked the question, how are you gathering the levels of intensity? Will you be following up with each flex program? And the answer to that is that we have a team here that I'm helping to train that will be reviewing each of your flex programs and creating, we're working through the idea of that framework now and levels of intensity. I have no problem sharing that, and I think whether we do it with all state flex offices or we do it with as part of a webinar where we get your feedback, I think it will be very helpful to do that. One, it'll be no surprise from any of you, to any of you, that everyone writes their flex applications and their progress reports differently. So it's not always easy to compare across when we try to capture some of this information. So we will want input from all of you in the field, because that, I think, will make it better.
And it looks like Kyle is typing in a question right now. In Wyoming, MBQuip data is used internally at Wyoming Department of Health, and every CAW that participates or that requests funds must also use MBQuip to measure improvement. And it looks like Catherine has a follow-up.
Okay,
Go ahead, John.
I was going to say, so Kyle, I think it's important that you're using that as part of an MBQuip feeds into PIMS in terms of who's improving and what hospitals are not. And I think that's helpful for all of you to use that. To the extent to which you're not having to deal with multiple measure sets across different stakeholders within your offices, be it the state government, be it FORHP, is important. Trying to keep it simple is important. And Catherine's question was, will some of your ideas be incorporated into future PIMS reporting? And we will provide that feedback to the federal office. There are limitations, but I suspect that as we work through this and figure out some of these factors, that we will certainly make recommendations, and I suspect some of them may be seen in future PIMS. Won't happen quickly because there's a whole process, and everyone is worried, of course, about changing the rules mid-game. But I suspect as we go through this and we all gain more experience with using PIMS and what we can do from the guidance side, we'll be making a difference. And so we'll be learning from this process, learning from all of you, and I suspect it will find its way into PIMS reporting at some point in the future.
Yeah, and that makes sense. As we, have seen throughout the Flex program, as Sarah mentioned on her PIMS webinar the end of August, trying to reduce redundancy and things like that are always, I think everyone from TASC to FMT, ARKITA, and ORHP, we're all trying to reduce redundancy and that data burden, both for you guys as Flex coordinators as well as for the hospitals. So if one place for data into PIMS makes sense and is a good source for data, then that'll be the hope or the goal. So I think I agree with John that.
Well, and please understand, as we all have different roles to play as the evaluation, and we're not an evaluation team that's out to point out flaws. Our job has really been as the way I want to phrase this, an interested but dispassionate partner. And so our goal is to try to be helpful, as we all are. I mean, none of us want states to do anything but succeed. Over time, the Flex program has become narrower. We've learned a lot over the course of 18 plus years for some of us. Certainly some folks at TASC have been involved that long, as have I and Ira Moscovice and some of the other folks and Andy Coburn at the Flex monitoring team. But our goal is to sort of provide a critical analysis that can help everyone to do their jobs better.
And on that topic, Mary Jane from Illinois asked whether or not the financial data and examination that you guys are working on at the Flex monitoring team will be utilized to provide recommendations for activities and programs that Flex Flex programs might implement or offer to their hospitals.
Ultimately, that's the goal. So the second part of this project, we're certainly going to be creating the framework of measuring intensity of performance and the depth, for lack of a better word. We're still working out through some of those, and when we do the analysis of all your Flex grant applications and progress reports over the 3 years, we're going to have multiple team members reviewing and calculating and capturing this information from your applications. 2 different people will each do a state, then we'll get together as a team and make sure that we're all scoring and assessing it the same way. So it'll be a fairly labor-intensive process. The second part of it is we will look at, and we will do some qualitative interviews, much as we've done with the innovative models and other programs, to just visit with some of the states to try, as we go through the data, if we're seeing something that seems to make more sense, is more helpful, or serves as a best practice, then we will try to highlight those programs. So I think in the long run, the goal is, yes, that we will be able to provide information that will give states some ideas about how to proceed in the future. It won't be prescriptive. We won't be saying you've got to do charge master reviews, or you have to do lean management. But I think probably would take the form more of how do you engage hospitals? What are they doing? If education is being done, how do you maximize the benefit of the education? Things like that.
Yeah, and I think it makes sense to have, some thought and examination into that, because the different, an hour-long webinar once a quarter is going to have a different impact than on-site process mapping and process improvement training or lean training, something like that. And I think it's important to have thought about those things and worked with, if you're working with a contractor or doing it from your office, those are all important things to consider.
Exactly, and in a lot of ways, I know I approach this from the evaluation side, and if Lisa Davis on the phone, I know what she would say to me. Lisa's a long friend, so I can say this. We differ in how people should use logic models. And Lisa will tease me about the use of them. But I think it's really important, as each state prepares its recommendations, proceeds with, you will have a new competitive cycle coming up, is really thinking about each of your activities and thinking very honestly and critically about how you would assume this will make a difference. And I know that's a challenge, but I think the strong Flex applications are those who understand how what they do and what they're proposing to do will drive the performance. Too often it's like 2 scientists. There's an old cartoon about scientists around a bulletin board, and they've got equations on one side. They have outcome equations on the other side, and they said somewhere here in the middle is where the magic happens. And too often we approach it that way. And so as you think about what you're proposing to do, I'm just trying to think clearly about how it will impact the performance of hospitals in either revenue cycle or financial performance or operational improvement, and then from that begin to think about the interim measures that will lead towards changes in PIMS and performance improvement. You know, there's a lot of noise in your systems. What third-party payers and your state Medicaid programs do around their reimbursement rates has a tremendous impact on financial performance. I've told this story, I think, to some of you in the past, that we had a hospital in Maine that was going through conversion to critical access hospital, and it was a rural town, and the big industry was the paper company. And it's been a long time paper products and forest-based economy. And about, I think within the same week that the hospital received its notice of CAH designation, the paper company closed. And the primary source of commercial third-party payment went away. And while the hospital was performing as well as it could in terms of efficiency and billing and those sort of things, their financial performance dropped. And that was something outside of its hands. So you need to be able to think about these sort of contingencies and what are the unexpected challenges, and also understand that there are ways of measuring. You know, you may not perform better in terms of cash if the bottom falls out of the local economy, but you can still be doing the right things in terms of making sure billings go out the door and that you're operating efficiently. So understanding those component parts is really very critical.
And I think having an understanding of the current state of affairs within your state as much as possible is very helpful. You know, if you know that paper mill just closed in that town, you're going to be able to have a different conversation with that CEO about what you can do to help support their needs than if you have no idea.
Exactly.
Any other questions for John? One of the other things that I wanted to talk about today is what flex programs are doing with some of the PIMS data that you enter into EHB every year. So there's an opportunity to just have some of that high-level data as far as, hey, if I have 30 hospitals in my state and over the last 3 or 4 years, I've seen the numbers of participating hospitals in this activity start to dwindle. It's gone from 25 hospitals 2 years ago to 20 hospitals last year, and now this year, as I'm gathering my data, I've seen we're only at 15 hospitals. There's some information that can be utilized while submitting that data that can be used to inform programs and services within your state. So before we move on to that discussion, do we have any more questions for John? And I assume he'll be here throughout the duration of the call, but
yes, I will.
Hearing none, Scott Daniels from Hawaii has agreed to chat with us a little bit about his process and how he goes about gathering data, whether or not he utilizes the data collection tool that we have available through the task office, and answer some questions as well. Scott, are you unmuted? If not, *2 will unmute your line.
Okay, now I'm unmuted.
There you go.
Okay. Yeah, no, when Caleb asked me to present on this, I reported back and I go, I don't know that our office has anything close to what others would see as best practices, but I do have some hints on basically entering into Pims and sort of what the process that we go through. One of the things, and if you were on the call with Sarah a week or two ago, I'm forgetting when that was already. One of the things I'd asked is about the timeout. One of the things that I've learned is, because every year it times out on me, you're always having to save. So one of the things actually that's useful for when you're entering into Pims is basically just to print out the questions beforehand and then fill them out. And then that way, this is what I always eventually end up doing anyway. After the first time, it times me out and I lose all the data that I put in. Just print it out, answer it separately, and then that way when you go back into Pims, it all just plugs in. I have used the tool in the past. I do find it useful, but most of the tracking is just basically I sort of keep track of the things that we do all along, and I'm sure most offices do this, is basically because I find a lot of the information that I gather, that I need to gather basically for writing the grant or for the extensions or for the supplements for grants, is information that I'm gathering a lot of the times for Pims anyway. So the only thing that's sort of new and a little bit more is the bit on the the financial, which was that new last year, or did they implement that the year before?
I can't remember, Scott.
Yeah, okay.
I feel like it was the year before.
What, it was the year before?
I feel like it was.
Okay, I feel it sprung on me last year, but it may have been the year before. But that's the one that I still don't have quite an exact. I don't necessarily monitor for each of the sessions that I do. Cost. I know how much the whole thing costs over a year. I don't know what each individual session costs, but I'm trying to get a better breakout on that for the future as we go forward. But like I said, a lot of the data that I'm gathering, I'm using for the grant anyway, and for the reports that are required by F4HP beyond other than. Whoops, yeah, sorry.
No, I think you're good.
Okay, I thought I heard something. But I'll leave it there. I don't know if Jill Bullock has more to add or not. Or if there's questions, like I said, I'm willing to answer whatever questions I can, but I didn't prepare really a presentation around this. So.
Star 2 to unmute your line. Does anyone have any questions for Scott? Do you feel, Scott, that it's been helpful? Like you said, you're kind of collecting all this stuff anyway. Do you feel that it's been helpful to have this data, to be able to look at it? And I think if nothing else, it's more data in another context, so it provides maybe another perspective for you to look at your data.
Some of the data is helpful. Some of it I feel I'm just filling out to make sure that I'm in compliance with for F4HP and everyone else. And I mean, just to be honest on it. So I mean that's sort of my feeling, because there are times when I'm dealing with Pims and it's just frustrating because I'm going, what the hell are you asking me here? Are you asking me that? And there are times where they've asked questions, and the way they ask the question and the way I fill it out, and then they say that it's not adding up correctly. And I'm going, but you asked me this, and then now it's saying this, and now I can't do this. And so sometimes I find PIMS to not always be the most useful, just because I'm not always certain about what it's asking. Some of it is useful. Like I said, if nothing else, it's useful for helping me to organize what are the things that I sort of need to gather for PIMS, but it also is, like I say, it's useful for me to sort of think about what are the things that are interesting to a potential reviewer in the future, and what are the things, and it's kind of interesting. In the past, you know, there's that whole thing between process and outcomes, and counting things versus is there real improvement, and so as we move more and more towards outcome measures within the Flex program, I find it interesting that PIMS seems, to me at least, to be more in the bean counting, how many things did you do type of thing. So in that respect, it doesn't quite give me the information that I want in terms of doing the improvement measures or doing the improvement things that I want to do. But I'm collecting that data anyway because that's what I'm interested in. Now they do ask, you know, they do sort of ask, did this hospital improve or not improve? Again, but it's more of a yes, you know, yes they improved or no they didn't improve, not a thing on how much did they improve by, what were the things that you found, what were the things that you implemented that you found to, I mean, it's not a, PIMS isn't capturing sort of what I'm looking at in terms of best practices at the hospital. So on the, like I say, it's useful basically as an organizing tool for how I might go about collecting stuff. I don't necessarily find the data in the end always that useful for the way that I'm going to move forward with my own program. Sorry.
Yeah.
That's
No. And thanks for that perspective, and I think that's important to know. And as Sarah mentioned and indicated on the PIMS webinar last month, as you guys are completing your PIMS reports and submitting your data, please do provide feedback and suggestions on ways to improve the process, the information. If there's something that, you know, as you're going through, you continue to say, I'm not quite sure I understand this question, you know, send it over here to task. We're happy to see if we have the answer and find it, or to push that up the flagpole and ask ORHP for a little clarification. And even if it doesn't improve things right then, the more feedback we have, the more opportunity we have to improve the data collection tool with the data scenarios that we have, the examples that we have, and then as we continue with PIMS in general, I know Sarah is always interested in making it as reducing the burden as much as possible. So we want to make sure to mitigate that as much as possible. We had a couple of questions and comments come in.
go ahead. As far as printing, is easy to print off of EHB? Yes and no in that you can just hit print and it'll print it out. No in that you do get sort of a long list of printout on it. But that, like I say, I find it's easier just to work on the questions at my own pace off on the side, because I'm always, if I try and work on it on the computer and go, oh, answer each question on the computer, I always end up forgetting to save, and I always end up losing all the work that I've done up to that point. And so if I print it out, and then that way I have the questions in front of me, and so then I can do the work and answer it, and then I get all the answers done. Then I go back into EHB. Then it's just boom, 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 boom. I never get timed out because I'm just putting in the answers now. So like I said, on the one hand, it's easy because you just hit Command or Control P and it prints out, but you do end up with a lot of paper.
And that's something else that, and for me here at TASC, please let me or anyone here at TASC know if the data collection tool is not as helpful as it could be, is not helpful, could be improved. Now is the time when it's fresh in your head. If you're getting there and you're saying, hey, this is another tool that I need to fill out just to fill this out, and it's burdensome and it's not helping, please let us know, and then we're always in the market to improve tools and resources we have. We do not want to create something that's more burdensome to you guys.
Right, and to be fair, I think I've used the tool once, and so I don't really remember my experience with it. So I remember it being vaguely helpful, but I can't speak more to it. So if I used it more, or if I had it out here in front of me, I could tell you where I found that it works better or didn't work as well. But like I said before, the tool existed. I just printed out and found that's sort of what I got around.
Yeah, that's what I did when I was a flex coordinator as well. I just went in, printed everything out, and then that way I knew what data I was looking for.
Right.
And I know some. Okay.
I was going to say, Kathleen, yeah, improvement is subjective. It's and that, I mean, I was one of the people that was arguing that people that are 100 and stay at 100 should be counted as improving. And they actually did put in the box of just sustained high performance, just because of how much effort. I mean, yeah, it's an effort to get them up to 100, but it's also an effort to keep them there. And then, so I sometimes, yeah, like I said, the question on did the car improve or not. Sometimes you don't have, when you're looking at numbers, and so I try and be fair with the numbers, but and so if the numbers say they didn't improve, I do mark it down as it didn't improve. But if they've had a bunch of turnovers and then they still managed to managed not to get worse, or they only improved marginally, I'll still mark it as not improved, but in my own notes on my own thing, that they've done a fantastic job with all the turnover that they've had and managed to do a great job on it. I also try and note, like, we have some very, very small volume hospitals here. Lanai has a population of about 2,500 on it, and they don't see many acute care cases at all in the hospital. But every now and again, they'll get something, right? And so there was a case in which, they didn't have an AMI for years, and all of a sudden AMI came in. They had the one heart attack that came in, and they got all the proper care. And so I try and note when things like that happen, how difficult it is for someone who never sees these cases, to when that case all of a sudden occurs and they score 100%, that those incidental things, that sometimes that's a bigger deal, even though they don't see them a lot. But that's why it's a bigger deal, because it's not something that's drilled into them constantly by, you got this case, if you get 5-6 cases a day, that yes, there's an opportunity to make mistakes, but it's also an opportunity to make sure that you have your processes in place. If you only see one every year or two, It's really amazing whenever you get those, that they get 100% of the care. That means that the processes are in place that they make that care happen. So I try, and again, there's not really a place in PIMS to sort of note that, but it is something that I always try and note, even and doing the did they improve or did they not improve. That's always something that I keep in the back of my mind when I'm going through that with the hospital, at least for my own notes to note and to make sure that I know note that with the hospital that they've been doing a great job, even though I may not be able to note it on PIMS. So.
And that's something worth noting, worth mentioning, and that I wanted to make sure to bring up on this webinar is that PIMS or MBQuip for the hospitals, or even your grant submission is not, there's not necessarily one place for all of that information. You know, PIMS especially is not going to capture all of that data. Your work plan isn't going to capture all of that data. Your narrative helps, and I think the entirety of that picture is really what we're looking for. You know, the federal office has access to all of those things. PIMS is one tool that the federal office utilizes to tell their story to Congress, to funders, to themselves, to others. The narratives and work plan are another thing that they utilize to help supplement that. But I think that's a great example. There's not really some place for that story to go into PIMS. There's not really some place for that story to go in your work plan. But there is a place for that in your narrative, and there's a place for that story in rural route that can get shared with the federal office and with other critical access hospitals. So the important thing is is to remember that there are opportunities and avenues to keep that information and to utilize it and to share it, especially with the hospitals that we deal with. It's very, very difficult to capture those things because they're not done often enough to say, hey, look, 99% of the 10,000, you know, AMIs that we had last year had the appropriate care. And in Scott's example, one of the one did have everything. That, you know, that data point does not tell a very compelling story, but that narrative does. That write-up from Scott and you know, highlight in rural route or at a conference or just talking about it on a webinar with others, that really does tell a story, and there's plenty of opportunity for those. So please don't think that, you know, PIMS or wherever is your only opportunity to tell those stories. There's a lot of success with that doesn't get captured just by those data points. And I know some flex programs utilize just parts of the data collection tool. Marcy in Colorado said that they utilize a combination of their CRM, what is CRM?
Customer relationship management.
Customer relationship management, thank you, Shannon. Software to help track activities and an Excel tracker to capture progress and improvements, as well as obtaining progress improvements from each hospital on a regular individual calls and site visits. So there's opportunity there to utilize a couple different things to capture the PIMS data as well as the improvement and participation. And I think improvement is also worth mentioning in light of Catherine's comment, that improvement will look different depending on the activity, and that might be something that John can shed a little bit of light on, because improvement based on a webinar, information and being informed is a different level than I expect a different outcome based on a webinar that you participated in. I expect that to be different than a charge master review outcome. So that improvement is going to be different, and it ought to be in my eyes.
And I think we're thinking very much the same way, although, you know, it'll be interesting to see if we can begin to tease out that difference and prove a point. Now, I also have to think there's a cumulative effect of involvement and engagement with the hospitals, both education, keeping them informed is helpful. Having CFO meetings where the CFOs get together and discuss what they're doing and they learn from one another, producing periodic reports and the like, as well as direct interventions where a hospital either gets formal TA either from the state office directly or through a consultant, whether they undertake sort of a cohort-based educational performance improvement project. Teasing out which of those things, I mean, I agree from just a logic point of view, we're assuming the more active participation has a better impact on outcomes, but I think it may all tie together. So, yeah, this is going to be an interesting. Project, and I think one that will help all of us think through some of these key questions.
Yeah, I'm excited to see that and to see how it starts to come together. We have just a few minutes left. It looks like Jill will not be able to join us today unless she's on the phone and not logged into the webinar. Jill, were you able to get dialed in? *2 will unmute your line. Hearing nothing from Jill, are there any other comments or questions? I see Melissa has chatted in that Jill is out on travel today, so won't be able to join us. Thank you, Melissa. Are there any other thoughts or questions for Scott or John, or comments for the group? Hearing none, I'll just, as Kyle Cameron from Wyoming is typing, I will just make a couple notes that, you know, to the previous point in relation to Scott's comments of PIMS is not designed to be a collection for all of your outcomes, for all of your efforts. It's it has limitations, but I think Sarah in the office is aware of that. But there are some really good opportunities that the federal office is able to utilize based on that data. And you know, I think one of my thoughts is, if I remember how difficult it was rolling up participation and improvements and data from the 30 hospitals that I had in Colorado when I was a flex coordinator, and rolling that up for information to the federal office. So when I'm thinking about the 45 flex programs and the 1,300 critical access hospitals and the diversity of the programs and services, from Scott's webinar on transition to value and the financial implications of that, and Stephanie's webinar in Idaho about a totally different thing, to be able to roll that data into one or two data points of participated, of Scott's dozen hospitals, 10 of them participated, and of Stephanie's 20, 18 of them participated, and to be able to say, based on that participation, improvement was made or not made. I think that's a really cool opportunity that we have to be able to tell the story of 1,300 hospitals. And I think there are opportunities for improvement just like there are anything else. And I do invite each of you guys to utilize the Flex Forum if you have questions and or needs while you're completing your PIMS reports. Many Flex coordinators have submitted their PIMS data before and might be able to answer your questions, especially if you're new and this is a new scary world of PIMS for you. Please don't hesitate to reach out. The Flex Forum task@ruralcenter.org is our TA email address, as well as any email address at ruralcenter.org. If you have a question, we'll find the right person for you. And as always, I know the federal office is there to answer any questions, but please don't hesitate to reach out to us, and we will either find the answer to the question you have or gather feedback and improvement suggestions and provide those back to ORHP. And Kyle, thank you for participating in the webinar today and participating with questions and comments. If there are no other questions or comments, I will direct you to the post-webinar questions to see if we've helped your understanding of PIMS and or ask you whether or not you've learned anything today. I will also thank John Gale from the Flex Monitoring team, as well as Scott Daniels from the Hawaii State Office of Rural Health for presenting or, talking to us on the webinar today. It's always good to have you guys.
My pleasure.
All right, guys. Well, thank you for taking the time to participate in the webinar. We understand how busy you are. As you're completing the final polling questions, I will remind you that the HCAPS vendor directory is all but ready, all but finalized, and will be posted on the website and available for download by the end of the week. The Small Rural Hospital Financial Summit report is out and available. You should have gotten an email last week about that. And the update to the Critical Access Hospital Finance 101 guide, which is now the Small Rural Hospital and Clinic Financial Guide, is available and updated. And the new and expanded material for that incorporates or includes a lot of transition to value information. So that's a great resource to start to have that, or to initiate that conversation with your critical access hospital CEOs, CFOs, and board members. It's a pretty entry-level information and understanding about the transition to value and what hospitals could start to and should start to keep in mind as they prepare for the transition to value. And if there are no other comments or questions, we will conclude today's webinar a couple minutes early, and thank everyone for joining us, and we will see everyone at the National Rural Health Association conference this month and the NOS, or annual meeting, the beginning of October. Thanks, guys.
Thank you.
Thank you.